Now, I would like to invite the next speaker, Dr. MAMTA KANKRA, who does not require any introduction because she is the leader of our webinar series. She has conducted so many webinars till now. I think all participants must be knowing her, but still it is my duty to introduce Dr. Mamta. She's the organizing secretary for KAHO CD, and she is the senior consultant, Department of Biochemistry, Quality Manager, Clinical Laboratory Services, Sir Gangaram Hospital, New Delhi. She is the chairperson of workshops in KAHO DD, corresponding member of IFCC, International Body, International Federation of Clinical Chemistry, CCB, and CKD. National champion for IFCC. She is also the lead assessor for NABL, and she has published many papers in national and international journals and authored a book and written chapters in various books. She has got more than 20 years of research experience in the basic and clinical biochemistry, and she is our brand leader, as far as KAHO Diagnostic Division is concerned. So I welcome Dr. Mamta KANKRA for taking us along with this topic, and she'll be speaking on laboratory stewardship in improving efficiency. Over to you, Dr. Mamta.
Thank you so much, Dr. Harsh, for such a wonderful introduction. And to begin with, I am extremely thankful to KAHO also for giving me this opportunity to take this forward, because conducting seminars and webinars and all has been always a passion and forte for me. And I'm also thankful to Dr. Malini because basically this was her session, and then she came up with this idea that we can include biochemistry also in that. So another thing that after listening to Dr. Malini's presentation, my work has become, a little more difficult, because she has taken presentation to a different level. So I will be basically touching upon how to optimize laboratory testing to improve patient outcomes, because stewardship is a very wide term. So when we, any one of us, when we visit the physicians, we often come across with so many symptoms. We see the detailed prescription, and it always includes the lab test. And we all know that labs are always an integral component and crucial in patient care, as 70% of the medical decisions are based on the laboratory reports. So it is central to the clinical practice, and it is interdisciplinary also. So it's not confined only to one specialty or something. So what clinicians or what the patients generally see, that they see that they visit the clinician, the test has been ordered and the sample has been given, and they receive the report. So this comes to us. But the long journey and the long efforts, hard efforts which goes behind the scene is actually not visible to everyone, and how much leadership, how much vigilance is required at each and every steps. So the requirement for patient safety is accurate, reliable, and timely test reports to all. That is either they are clinicians or the patients or any other user. So laboratory is not a place where only data is generated, no magic happens. It requires a complex integration of expertise in all the steps of laboratory functioning. And here comes the role of laboratory stewardship, which is a step further than quality assurance and quality control. Because most of the times the inception is that labs run IQC, internal quality control, and then they participate in external quality assurance proficiency testing, and that is the outcome. And these are the kind of schedules which labs follow. But after working in the laboratory for more than now 25 years, and being part of the administrator also as a quality person. So as all of you know, the total testing process is divided into 3 phases. And this was interestingly, this phrase, total testing process, TTP, was coined by almost 50 years back by a group of laboratory quality experts, including the Centers for Disease Control and Prevention. And in this, we can see that in pre-analytical phase, the chances of errors are maximum. That is more than 70%, as we can see. So here we need to pay more attention that what better we can do. And this figure in all the 3 phases has been quite consistent. So what all we need to do, what better we can make for that. I will just take you to the brief history that how the laboratory quality journey started and how the stewardship started. So in 1922, a group of 39 physicians, pathologists, and laboratory professionals, they came together, and their goal was to achieve greater scientific proficiency in clinical pathology. So this American Society for Clinical Pathology recognized the contributions and importance of both quality people and the processes to assuring reliable quality results. So that's why they were the instrumental in bringing American Board of Pathology 1935, which exists till date, and the famous College for American Pathologists Proficiency Testing Program, and it has celebrated its 100th anniversary. So after that, the good laboratory practices came, and this was first introduced in New Zealand and Denmark in 1972. And GLP is basically a set of principles that defines a quality system which is concerned with the processes and the conditions under which laboratory testing process is planned, performed, monitored, recorded, reported, and archived. And all of these requires a very strict vigilance. And the history behind why it was established that later in the US by FDA, it was found that in response to falsified and poorly documented toxicology data submitted by the certain organization seeking drug approval, most notably to the pharmaceutical company Industrial Biotest Labs, it became the headline news because it was a big lab that ran tests for big companies. And it was found that the mice which they had used to test cosmetics such as lotions and all, and they had developed cancer. And the lab threw the data, entire data, the dead mice, and covered the results, deeming the products good for human consumption. Later on, when it was found that whoever was involved in the production, distribution, and sales for the eventually served jail at that time. And that's why the role of GCLP, that good clinical laboratory practices came, and which WHO and ICMR are the leaders in that. And WHO published their guidelines in 2009, and ICMR released its first guideline in 2008, which was subsequently revised in 2021. So while these guidelines are basically for lab who does clinical research, framework for the laboratories who does clinical trials and all. So now comes to the question that what about the labs who does human testing, like testing on the patients who are doing clinical care, who are doing patients. So this national GLP committee on April 2022, and they give it this administrative control to the Department of Science and Technology. And that year time, it was accreditation bodies were established. Now they function under, that time they were under Department of Science and Technology. Now they function under Quality Council of India, which is part of government Ministry of Commerce and Secretary now. And medical laboratories based after that, after GLP, GCLP, now the medical responsibility of accreditation and international following, it comes for the accreditation bodies. So accreditation basically became the change leader. So with accreditation, so many things, documentation, leadership, and everything came, so many documents and processes, laws, rules, and standards which we needed to follow. So ISO 15189, all of us are aware, whoever is present, most of you must be aware that it is an international organization for standardization. And when it comes to 15189, that means it is for the medical laboratories. And by being accredited by ISO 15189 through the NABL or any other accreditation body, our reports are internationally acceptable. And these accreditation status are acceptable whether any kind of inspection, whether it is NABL, NABH, or any other statutory or normative requirement. And the accreditation status, so many of you, so the leadership, when we are coming back to the stewardship. So when we talk about the stewardship, whatever is happening in our organization, whatever we are doing, our responsibility, number one, as a leader, that everything is seamless, everything is perfect, and we are adhering to all the requirements of the accreditation bodies and to the law. So that's why when the accreditation, when we try to say we are accredited, and this is the kind of certificate we get, and this is the QR code, which brings the transparency. This is the beauty of this accreditation and the standard. So whatever we are doing, anyone and everyone can just scan it and see that whether we are giving the right statement or not. So this is the way we need to teach our each. And so when we talk about accreditation, which means that we are following so many things, whether we are receiving one patient sample or 100 or 1,000 of patient samples. So we have to adhere to each and every requirement. So is it possible, or is it so easy to adhere to the quality requirements? Yes, it is easy because quality is never an accident. It is always the result of intelligent effort. And the revolution came with the advancement of the technology when from the manual testing to the automation. So here comes the role of stewardship. So what is lab stewardship? Enhance patient safety and to assure cost-effective use of resources. As Dr. Malini also mentioned, optimize laboratory testing systematically, reduce unnecessary testing, promote. So we know everything, but how to do that? So I will take you through that how to minimize these errors across the testing cycle, pre-analytical, analytical, and post-analytical, and how to bring betterment and enhancement in the services. So the aim is to the 8 waste. So the defects, the overproduction, the waiting or delays, and not utilizing recognized skills, then transport, then inventory, then motion, and then extra processes. Whatever is extra, we need to remove those. So how it is possible? This is only possible once we try to introspect that are we doing our things in a correct way, in a right way. So we need to first introspect ourselves by doing the internal audits and by to investigate the areas of improvement, or is there anything which needs answer. So laboratory stewardship insights is basically a group of people. It is not the role and responsibility of only one person, on the laboratory director or the quality manager or the chairperson. It is a group of people. And it is that simple? No, it is not that simple. But if we have key pillars of laboratory stewardship, we can make it simple by doing the right test in a right way, right specimen, right interpretation, education and collaboration as we are doing today, and by monitoring things and taking the feedbacks. So the 4 elements of stewardship are governance, interventions, data extraction and monitoring. As Dr. Malini also mentioned, that artificial intelligence, this plays a major role, and we can go much ahead if we have our right data and we know how to extract and how to monitor it. And then when we have that data, how to review that data and how to bring the improvement in the system. So first and foremost responsibility for any leader is whatever kind of services, your services may be different, my services may be different. So whatever services you are providing, 24 hours, any 8 hours, 10 hours, or whatever kind of services you are providing, you must display and the plan of care for the patients. Because if someone visits to your hospital or to your diagnostic center, if you have not displayed your services, they will not come to know that what kind of services are you providing. So for that, we need to, and all the documents, and then we have to check. If I am running this as a leader, what are the mandatory requirements which I need to follow? So first and foremost is a clear vision of organizational alignment, that is objectives and policies for the fulfillment of the purposes, and which is, as we always know, that quality policy and quality objectives, and each organization may have different. But please remember, whatever quality objectives you define, just not use flowery language. Define those objectives which are measurable, for which you can show the data whenever it is asked, and translate the statements contained in the policy and objectives into a set of specific measurable objectives. Then legal and ethical compliances, that what you are registered with. And then as a leader, you should know what is required by the Gazette of India. For example, institutes who are doing human transplantation, organ transplantation. So what kind of tests, the DNA profiling and all, should be done in those tests which are accredited with NABL. And then the legal tracker, whatever the consequences or whatever the requirements of that particular. So these are the responsibility of lab stewards. And can we do it alone? Can I do it alone if I am a quality person? No, I cannot. I need a team of people and from all the specialties. So first, I then need to define the organization and the organogram, that how to all of us whom we can take into that, and who can be held completely traceable. So it's not only responsibility, and then whoever are associated with us, then we need to take a commitment in the form of declaration of impartiality and confidentiality, as we are working for patient care. So we cannot be partial to people, that we will be providing good services to a set of people or to a definite set of people. If I am from a private hospital, so only a set of people I will cater to. No, we have to, being a medical person or being in the hospital, we have to make them. So these are the things, everyone understands these words, and everyone has the idea that this particular requirement exists in the international standard or in the NABH standard or any other JCI standard. But how to implement, that is the role of the lab readers. So taking them commitment, then if you have already told them, you have taught them, so please take an undertaking from them that they have actually read and understood. Because many a times, being an assessor also, we have found that if it is asked from anyone, so we are not aware, we were not told. So these are the kind of traceability which you need to keep in the form of some document, and these kind of documents you can keep in any information. Any kind of form, that soft or hard copy. Then very important thing, release of information. When any hospital or any laboratory is required by law or authorized contractual agreements, so patient is coming to your hospital or to your diagnostic center, patient is giving sample, or any person. So do you tell patients or not? If there will be any result which falls under the notifiable category, that will be informed to the government agency or the regulatory agency. So many a times patients are not aware, suddenly they receive a call from the government body and so we have found your report. So please inform patients clearly and define a system in your organization so that it doesn't come as a surprise to any of the users of diagnostic services or the laboratory services. And for this, we need to have a proper documentation. So as I said, so many requirements, so many quality requirements. So is it possible to remember everything? No, it is not possible. So we need to formulate a kind of manual, and and so many documents are there. Is it possible to be if disorganized? If we will be, then it will be very difficult to retrieve. So most an important part is that good documentation is an essential requirement. Whoever is working in your team, whoever is working in your lab, they should be able to find it, understand it, use it, and share it, and return it to the place when they have used it. So this we have to teach them. So many a times we have found that, okay, document is with so and so person. So that means they understand that that is called document control. So as a leader, we need to understand, make them understand that that is not document control, and none of the documents of this kind are required to be kept under lock and key. Document control means that any document which is issued by the organization, by the quality person, by the lab diagnostic institute, or the chairperson of the organization, we need to have a ID for that, a document number, and that document number should be issued, because many a times we have seen it is prepared by, approved by, but not issued by. If you refer to the international standard or to the JCI, it always says that who is the approving authority. So after approving, so you can keep your document controlled in this way, and that shows you need to even put the stamp only if the number is there, and number is kept in the form of this kind of log, that is considered as document log. So basically, we need to have systematic approach for whatever we are doing, and not confiding, not just keeping those things to ourselves. We are sharing with all the people who are working in the lab, whether they are, and we need to prepare SOP for what area of functioning, whether it is sample collection, whether what is the purpose, whether it is the analytical phase, what scope it is covering, who is the responsible person for receiving the sample, for processing the sample, what are the different procedural steps from the sample receiving to the reporting report which we are handing over to the patient, and are we following any references, and what unique ID are we giving to each document. So if we organize each and everything in a neat and retrievable manner, so it will be very helpful and all user. So in our institute, I'm just giving you an example. We have a tracking system in which we have kept all our quality documents, which are accessible to each and every person who has accessibility to the LIS and the HIS of the hospital. So if you just click on that, you will find that all the related documents of NABL, NABH, any quality document are available on that. And as you know, and we have kept them on a non-editable PDF format, so that no one can even download it, no one can print it, no one can no one can make any changes in that. So this is called document control. So we are making them accessible easily, and this is saving paper also. So such a huge document, this contains almost 300 pages. So is it possible for everyone to just, for me also, or to anyone, to just keep hand over a copy? No. So as a quality person, or as a leadership in, as a leader in quality, this is the way system should be devised by any organization. And these documents should be kept in a sharing mode so that everyone can access them. Then infrastructure, but the kind of services you are providing to your to your patients, whoever is coming to you, if they require any kind of services which need to be 24/7, so have you looked into that all the services are being provided 24/7 or not? If not, then we need to look that at least some part of the hospital where phlebotomy services are available 24/7 for OPD patients also, who have come in odd hours, There also, public timings, if it is 24/7. So if there are other areas are open from 9 to 5 or 8 to 8, but there should be some area in the, so as per the services you are providing to the patient, as per the requirement, you need to define all these, and then service agreement everyone knows, then sample collection everyone knows. But yes, for especially disabled children, differently abled people, people with different needs, we need to have a separate area and different facility for the elderly. We need to define. So all these, everyone knows, we collect the sample, we report, but these are the activities which comes under that. Any special requirement for any particular sample, then any consent is required, like for example, for FNAC, for HIV and all other tests, if any consent is required, special, we need to take that. Then if, as I said, we release the information, then how are we releasing it? Then if we are transporting the sample either manually or through the chute system, are we supposed to, then your people who are working in the lab, or people who are phlebotomists or clinicians, if they are sending sample to you, they should be very well aware that these are the requirements of this particular sample that can be sent through chute or that can be sent through the, so these are the requirements which we need to tell each and every person, whoever is working in the lab. Then CDC guidelines, and then transportation record. Because many a times it is observed that people say that we had sent the sample on at so and so time, but the lab always fights, no, we have received sample now. So we need to keep a transportation record, and I'm not saying that you need to keep it in hard copy only. If there is a provision, you can show it or maintain it in the soft copy, please do that. Then centrifugation. This is also an observation being an assessor. Many a times labs are not aware that different types of samples needs different types of centrifugation. So you as a leader in your organization, you or as a quality person in your organization, you need to tell them what kind of sample, how many RPM, and how sample has to be, then what accommodation and environmental conditions are required where you can function properly, and all the safety facilities and all, they are available, fire alarm, sensors, and whatever is required for the safety of the people, and eye wash, and this is another important thing. These things are available, but people are not aware where they are available. So repeated trainings are required, so where we can tell them that these are the organization, these are the property of the organization, these are for use of everyone in the event of any mishappening or in the event of any emergency. Then infrastructure, readily available information, equipment everyone has, but people are not aware how to switch it on. So readily available information, and whatever you are doing, you just record it, whatever list of equipment you have, what time of breakdown record. So because this can have a traceability. So these records are our responsibility. Everyone knows, okay, we have equipment, we have to do PM, but how to record that, this thing. Then if you have a huge list of equipment, because you are a multi-specialty hospital, you have diagnostic services where you are providing each and everything, then you need to assign the responsibility to people that which particular equipment is being looked after by whom. Yes, we can train everyone, but a traceability or the responsibility or the liability we need to give to the people. Then when the sample is received, as a this was also an observation, when we many a times clinicians say someone went to the lab, but there was no one in the lab. Then you identify what was the problem. Problem was it was the late evening, less staff in the lab, then people were working inside the lab. So a bell was put to make easily contactable, so that if the phone was not being picked up, so the people can just approach the lab and just deposit their samples. Then where people are doing automation, the problem comes with the quality of barcode. So these are the things, when we start with the sample, tube has come to the lab, barcode is pasted on it. But what is the problem with the why tube is not being scanned? Why we are not able to do the interfacing, bi-directional run of that sample? The problem was when we identified, when the report came to us, that the barcode was of poor very quality, because it requires minimum 300 DPI, dots per inch. So these 300 DPI dot per inch are not available, then the machine will not be able to read that. So we need to take action on these things. Then personnel are the backbones. We should have adequate number. We should train them. We should, as I said, impartiality, everyone should be aware. Then the job responsibilities, whoever is doing what, and the job responsibility should be received by them also. And then regular training. So when we give them induction training, when anyone joins any organization, laboratory introduction must be part of their induction training, whether they are nursing staff, whether they are clinicians, or people who are working in billing and area and any other area. So after induction training, whenever people come to your lab, give them proper induction training. So this is required to streamline everything so that there are no mistake in each at any step of the laboratory testing. Then regular trainings, whatever is required. Phlebotomy, we begin with phlebotomy, that's why. But in addition to that, BLS and ACLS training, then facility management, and if there are any grievance redressal, patient employees' rights and responsibilities. So it's not only we, as a leader, we are not focused only on the testing part. We are overall, we cover encompasses everything, whatever can make people comfortable and they can give their 100% input when they are working. Fire training for their safety, disaster mock drills, and if there is any mishappening or in the wrongdoing in any report, either from our end or from the patient's end or from the phlebotomist, how to recall or make amendments in that report, people should be very clearly available, because that can lead to medical legal cases. And then we should encourage our technical staff also. So to take these kind of trainings, once we have taught them, so basically train the trainer. So as a leader, we should tell them, okay, you take these topics. Now we have taught you for last 2 years. Now it is your responsibility that disinfection of you can pick up any topic as per the functioning of your lab. And time to time, we should educate our clinicians on the role of laboratory services in patient care. In addition to that, as a leader, we should give regular trainings for health and wellness also, in the form of yoga or any other activity which can bring everyone together and which can de-stress people. Then we monitor their competence. We all know then their technical competency. In addition to this, we also conduct various camps and we organize these activities by to make realize everyone. So what we are doing, it is not confined to ourselves only. We are providing that facility to the other part, especially to the economically weaker societies of the organization. And whatever we do as a leader, we try to train everyone in a collective manner. And any laboratory activity, as you can see, we have a team of clinicians as well as the laboratory director, other laboratory HODs, technical staff, and people from blood bank and all organizations. So try to organize these kind of activities which are common to all, and try to teach, because as we said in the beginning, that pre-analyticals, they cause 70% errors in the total testing process. So these are the only ways and means where we can minimize or we can reduce those errors, and in maybe in another 4 or 5 years we can bring them to maybe bring down them to 20 or 30%. So as we said, phlebotomy training, workshops and various workshops, and social welfare initiative. Take any initiative you can take, reach out to people that you provide them free ambulance services. And also these are the leadership qualities which any organization, and then try to educate family and counsel them once they're admitted in your hospital or they have come to your organization or to a diagnostic center. If they have any report in their hand and they need what understand. So we just can't send them back. Okay, you go to the clinician, they will tell. No, as a laboratory, it's our responsibility. Act on their feedback, whatever they tell you, just work on that. And if someone calls you verbally, so if someone sends you verbal information that we want to get this additional test done, so please define, because technician will just pick a phone and they say, no, we will not accept it. But yes, there is a way where you can accept. So educate your technical staff. And I'm sharing all these information on the basis of the observations which we had in last 4 or 5 years. Take staff suggestions that how we can make system better. And by weekly meetings or monthly meetings and all, and just note them down, because no one can remember what meeting was held, what was the problem discussed. So just note them down and just try to act whatever we can implement. And these are the areas where purpose to achieve higher levels of performance. You are doing testing, you are receiving sample testing and reporting. But if you want to go higher, so we need to take quality initiative as a stewardship by monitoring our turnaround time, by saving paper. As I said, we have to document so many things, but we can't keep everything pile of files and all, because we don't have that much of space. So we all of, as Dr. Malini also said, so much of waste is there. It is not easy to discard paper, plastic files and other plastic things. So try to save papers, do paper saving in the form of various these are available. And the next step, how we can, as I said, 4 pillars. So the only thing which we can bring improvement is that if whatever number of tests we are receiving, so we just analyze them. Are there any errors in that? Misdiagnosis, delayed diagnosis, or there incorrect diagnosis on basis of that? Did we need to revise any reports? Did we need to reject any sample? or there were too many hemolyzed samples we were receiving, and or we did too many redos. So all of this can only come when we will compile our data. So on papers, it is not possible. So we need to have a soft copy, or we need to have an Excel sheet where we can just these kind of, this slide is very cluttered, but in this slide it is shown that these are the tests which are highly specialized tests and which are very low volume tests. So what is the growth of these volume tests, as you can see in the bar graph which is being shown? So can we make some change in the turnaround time, or we on the days of testing? So these are the kind of data which is required for bringing the improvement in the system. What kind of, if you are doing allergy testing, for example, what kind of allergens you are getting more? So if you have analyzed this data, then you can increase the availability of these kind of tests in your organization. And these are just the graphical representation. How many number of controls were run? Was it required to run so many controls, or was it required to reduce the number, or we need to some capping? What kind of turnaround time are we following? And if there are any special requirement pertaining to sample, that for example, ammonia and lactate sample, they need to reach the lab within 10 minutes. In this, you can see that in January, in the pink graph shows that samples were reaching beyond 15 minutes to the lab. And when we tried to follow up each and every sample which was coming to the lab, then we found that there was a slow progressive improvement. And we could see that in March first half, there were only 7% of the samples which were not part of, which did not reach the lab in 15 minutes. And in March, we found that each and every sample till date is receiving, because of within 15 minutes time, there is no sample which is crossing 15 minutes. So these are the kind of activities as a lab people, as a quality people, that we need to. Same is for lactate sample also. So we followed up for ammonia and lactate both. And then the clinical correlation, equa reports, double billing. Another problem which we have come across in many of the organizations is double billing. If anything is part of the profile, and that test is also, for example, this is an example. This test was ordered as anemia profile. And in the same patient, TIBC, iron, serum iron, ferritin were also ordered separately. So this is not the problem of the patient. This is the problem. Patient had no fault. This is the problem of the system. So we need to devise a system. Then we need to put a pop-up there that please do not, and this pop-up is required by whom? This can provided by the IT person, and this can be implemented. So we need to teach our billing clerk. So if you are ordering this test, please do not order them together, because this costs also a lot. So if a patient is paying for the anemia profile, they have to pay for the 3 extra tests. Then misidentification errors or wrong barcode, mix up of samples, and people say that, sorry, I took patient this sample. So for that, we need to provide retraining and training. So, and whatever you observe, just put them in the register, either in the form of a soft copy or in the register, so that whenever any kind of mistake happens, then you can just tell your staff that this is the time. Earlier also this has happened, so you need to bring improvement. And another important thing, how we can, whatever I'm talking about data and all, this you need to have some sort of a quality indicator for that, as I said in the beginning. So we need to have quality indicators, and we need to define the target for each and every quality indicator. And quality indicators should not be limited only to the pre-analytical phase. If they have more errors, more literature wise, they have more errors, we need to define our quality indicators in all the phases. And capture, only you can capture the data with the help of LIS or with the help of manual entries if you have low volume work, and change quality indicators once they show steady performance. So hemolysis is a major problem. In our hospital, we conducted a clinical audit for the hemolysis, and we found that when we followed each and every sample for hemolysis, so in a 1-year study, we found that our hemolysis rate was reduced to 0.87, which is lower than whatever is reported even in Asia. So we were very happy to say that we came down to that level. But was it possible? No. This was possible because of the Herculean task which we followed. Each and every sample, as you can see, we followed for each and every sample, how sample was collected, how the sample was taken, how the sample was transported. Another, barcode rejection, why does it come? How we can make the improvement. So remember, single mistake can significantly affect clinical decisions, severe consequences, and bad quality. Good quality is invisible to everyone. You all must be aware, and bad quality is difficult to overlook. So just do something treat each and every sample, like for urgent samples, identify them separately, label them. If they don't come labeled, just get back to the clinician, get back to the ward, get back to the phlebotomist, and your samples are not coming like that. Critical value notification. As per the ISO, they say that critical value should be identified in the final report. If you have limitation that you cannot identify, then devise some method with the help of IT, that with some black background, with some red thing. So whatever way you can devise, and in the final thing, and send SMS to the clinician, and then keep a record through the LIS. Because I personally believe it is adding just wastage if we are doing everything manually and keeping everything in the form of files and all. And then, as per the requirement of ISO, identify the critical value, whatever you are giving to the patient, that this is the critical result notified. So if any patient tomorrow complains that we did not receive the notification, so this is the example. And then you see that in by doing this kind of, not by telephonically informing or just noting down these values, how we have improved in last from 2020 to 2024 with the help of LIS, we have improved so much. Then these are further beyond that sigma metrics, how we can another way of improvement by monitoring our performance. Then conduct various webinars, like we conducted, whatever is required to be commemorated. Try to bring those activities and those kind of things to people, organize conference, and try to take pertinent topics. And as we are part of professional exchange program, if you can educate people from the other countries also, even underprivileged countries, try to educate them. And then social welfare initiative, I already mentioned. This was, sorry, this was duplication of slide. And then achievements, whatever you achieve, try to share with your people and encourage them, because as a leader, it motivates. Then if any awards, phlebotomy championship, as like KAHO is also, KAHO Diagnosticon is organizing this mega quiz to encourage your phlebotomist that please part in that, so that they will be very much they can get idea that other than whatever. And whoever is working in your organization, try to motivate people by giving them various awards, long service awards. In our hospital, we are very fortunate that long service award is given, so people get motivated. Whatever you do in the form of books, chapters, publish them. Whatever data you have, and whatever kind of patients you have, try to do research projects, whether you are a small lab, if you are working in any remote area of India or remote part of North India, South India. So we have different population. So try to collate the data and try to do the research projects, and take everyone in that. It is very important. So, and then try to develop the skill of people who are working for you, start a stewardship committee, and educate clinicians and take feedback from clinicians. It is not only with us that we are doing very well. So we should not have that ostrich kind of therapy. We should try to reach people. Then, as per the requirement of NABH 6 standard, POCT has come under labs now. So try to make a SOP, or try to devise a system that how many POCTs we have in our organization or in our even diagnostic center, and what kind of test we are providing them, that what kind of critical value notification, and what kind of how many times it requires calibration. So please keep all the data according to that. And whatever you are doing, try to evaluate everything, that are we doing over budget or under budget, if we can improve something. So we need to do whatever test we are doing, we need to improve the system by defining our policies, by looking into our policies. And we need to integrate many educational and scientific tools for the implementation of these practices. And translating the good quality of research into every practice is very, very important. So keep updated with your mandatory requirements. So we always say the journey is not limited only to the patient and to the pre-examination examination. We need, as a lab people, from the time the sample has been ordered, because there also it's a responsibility. We have told them that these are the kind of, until the time sample report is given, it is the responsibility of us and the quality team and our administrators, because all for one and one for, no one can do anything alone. It's a team activity. And if all of us will work together, and whoever is underskilled or whoever needs help, please pull them up. If someone requires training twice, thrice, I have shown you so many documents. So there may be many people that they don't understand what is the significance of this document. If they require more time, just teach them separately, because in a class, every student is different. So if you want to reduce burden on yourself, you need to educate others. So, and whatever, and tell clinicians, whatever is there, if there is any discrepancy in the result, tell them that you need to contact, because it's always not that clinical reports correlate. There could be many factors where the results do not correlate with the data and the clinical findings of the patient. And implementing quality management does not guarantee any error-free laboratory, but yes, with the experience, it detects errors that may occur and prevent them from recurring. And savings, when we do activities like that, samples are reaching on time, we don't need to request unnecessary. And if we are counseling patients, so we are preventing dissatisfaction to patient, skepticism clinician, because we are taking feedbacks from them. We are evaluating entire cost. We are fixing the days. So we are increasing the confidence of the clinicians, and we are increasing the confidence of the staff in doing the things. And accreditation, we always say it sounds that it's a voluntary, or it becomes a burden also many times to many people, but it is a mark of excellence worldwide. So we must follow some guidelines. I'm not saying you go for accreditation, but at least you follow their guidelines if it is not possible. And implementing these kind of laboratory stewardship is only possible by forming a multidisciplinary committee. Educate everyone, start with high impact tests, monitor, audit, and improve, and prepare yourself with contingency plan. If this plan fails, what is the next plan I will follow? And lab stewardship committee should have everyone possible, like CNO, phlebotomists, clinicians, director labs, chairpersons of all labs, and quality executives. As we medical laboratory professionals or laboratory professionals are people who are working behind the scenes and behind the cure, but we have to come in forefront and we have to tell them, no, this is required and you need to follow that. And you should always have some future planning that how we can do better and better. So thank you very much, all of you, for patient listening. And I'm very happy to answer any question if anyone has. Thank you.
Thank you very much, Dr. MAMTA, for taking us beyond IQC and IQAS. I think you have given a new domain, explained everything, for our participant, that how we can be a, leader in the field and how we can improve the quality of the lab. So thank you very much for your talk.